Cardiorenal syndrome describes the complex bidirectional pathological interaction between the heart and kidneys. In this relationship, dysfunction in one organ frequently initiates or exacerbates dysfunction in the other through shared hemodynamic, neurohormonal, and inflammatory pathways. The classification system developed by Ronco and Associates in 2008 is the gold standard for clinical categorization. In that classification, 5 types are described. Type 1 is acute cardiorenal. Acute heart failure like acute decompensated heart failure or cardiogenic shock leads to acute kidney injury. Type 2 is chronic cardiorenal syndrome. Chronic heart failure leads to chronic kidney disease. Type 3 is acute renocardiac. Acute kidney injury like glomerulonephritis or ischemia leads to acute cardiac dysfunction with arrhythmia or heart failure. Type 4 is chronic renocardiac. Primary chronic kidney disease leads to cardiac hypertrophy, fibrosis, or coronary artery disease. Type 5 is secondary. Systemic conditions like sepsis, diabetes, and amyloidosis leads to simultaneous heart and kidney failure. The vicious cycle of cardiorenal syndrome is driven by several key mechanisms. Hemodynamics. Reduced cardiac output leads to decreased renal perfusion. Conversely, high central venous pressure, that is venous congestion, increases renal interstitial pressure, reducing the glomerular filtration rate. Renin-angiotensin-aldosterone system activation. Both heart and kidney failure trigger the renin-angiotensin-aldosterone system, causing sodium-water retention and systemic vasoconstriction, which increases the workload on the heart. Sympathetic nervous system. Chronic overactivity leads to further renal vasoconstriction and cardiac remodeling. Inflammation and oxidative stress. Shared cytokines like TNF-alpha and interleukin-6 promote fibrosis in both tissues. Clinical challenges in cardiorenal syndrome are diuretic resistance. As renal function declines, the kidneys become less responsive to loop diuretics, making fluid management in heart failure exceptionally difficult. Creatinine bumps. During treatment for acute heart failure, serum creatinine often rises as fluid is removed. Deciding whether this is permissive AKI treatment strategy to benefit long-term cardiovascular and kidney risk or true renal damage is a common clinical dilemma. Management strategies include decongestion with loop diuretics as first line, often supplemented by thiazides or metronidazole to overcome resistance, that is diuretic resistance. GDMT, guideline directed medical treatment. Use of ACE inhibitors, ARBs, or ARNI, that is sacubitril/valsartan, though these require careful monitoring of potassium and glomerular filtration rate. Combination of ACE inhibitors with ARB is discouraged because of excess side effects. All these are mainly for chronic cardiorenal syndrome. SGLT2 inhibitors. These have emerged as a bridge therapy, providing both cardioprotective and renoprotective benefits. Ultrafiltration is reserved for patients with refractory fluid overload who do not respond to pharmacological therapy.